Yes, thank you, Associate Professor Lithuang Vu. It can be said that Dr. Vu's presentation was very interesting, and this once again confirms that Vietnam is currently one of the leading countries in the world regarding antibiotic resistance. And we also have an antibiotic that is still effective against all types of gram-negative bacteria, excluding Acinetobacter baumannii, which is amikacin, which has been verified through clinical trial studies worldwide as well as real-world studies at KHOA Hospital. Next, you have now heard the two reports. Now, we are very eager to hear the comments from the delegates as well as any questions for the speakers. We have many experts here. I see Associate Professor Dang Quoc Thuan, President of the Hanoi Society of Intensive Care and Poison Control, and former head of the Intensive Care Unit at Bach Mai Hospital. Dr. Thuan also has a lot of experience, as does Dr. Hoang An. You can ask questions, and if you have any difficulties, we will ask these two experts to provide answers. Yes, please go ahead and ask your questions. Before the questions, I would like to ask Dr. Thuan if he has anything to add to the picture of antibiotic resistance regarding the ESKAPE group at KHOA or our Bach Mai Hospital. Yes, I would like to cordially invite Dr. Thuan. If I may, the reports by Dr. Phuong and Dr. Vu were relatively comprehensive. So, I would like to ask for permission not to add anything else, to save time for our colleagues to ask questions and to address the practical issues occurring daily in your hospitals. Yes, agreed. Since we are waiting, I would also like to ask for some experience. Yes, please go ahead, Dr. Quang.
Yes. I am from the Institute of Hematology at Bach Mai Hospital. Yes, thank you very much for the reports from the professors. We found them very interesting and truly very useful for clinicians, microbiologists, as well as clinical pharmacists. We are discussing community-acquired pneumonia, as well as its underlying causes, especially regarding currently drug-resistant bacteria. In particular, we currently have an intensive care unit at our hospital, and we find the situation with drug resistance very challenging, especially given the recent difficulties with vancomycin, as supplies have been scarce. So, with this new 5th-generation antibiotic, ceftaroline, we have used it and switched many patients to it, especially for soft tissue infections, which are often caused by Staphylococci and currently present a significant disease burden. We have used it on several dozen patients and found it to be very effective. While it is true that it has activity in the community setting, however, in the hospital, as noted in Dr. Vu's report, it also shows activity against certain hospital-acquired bacteria. My only concern is that for organisms like Pseudomonas, it perhaps does not provide coverage. That is still a concern of mine. Honestly, we think this is an excellent additional antibiotic for treatment, as it is not just for Staphylococci, right? It also has activity against other gram-positive bacteria, such as pneumococci. Regarding Bach Mai Hospital, we recently, and this is not a question, we just want to add a recommendation. Perhaps Associate Professor Phuong's report should have included an image of the Bach Mai Hospital protocol. Our council has already approved it, with the participation of Dr. Hoang An and the Clinical Pharmacy Department. We have sat down and developed a regimen, a protocol for guiding the use of ceftaroline in the hospital. That would be very beneficial and could be adopted by other levels of care for implementation. Since this is a reserve antibiotic, we also need to preserve it and should not use it widely, so having these guidelines is very beneficial for our usage. And especially, in the near future, we hope it will be covered by insurance, and I think currently, at the, what is it called, the Department of Health Insurance. They have also been working to get this antibiotic included for use. Yes, that is all from me. Yes.
Yes, thank you, Dr. Kwong. Associate Professor Kwong. There seem to be many questions on the screen, and here is one. Dear professors, do current cases of CAP, especially severe CAP, have a high rate of multidrug-resistant bacteria? That question is likely for Dr. Fuang. Next, we would also like to ask you to share your experience treating CAP currently at Bok Mai University Medical Center and Tam An. First, I would like to ask Dr. Fuang to answer this question. Then there are two questions for Dr. Vu, the first of which has two parts. One part for Dr. Fuang, and one for Dr. Vu. Yes. Yes. Before answering the question, I would like to apologize to the conference for not sharing that recently, Bok Mai has issued guidelines on prescribing this new generation of antibiotics. Because recently, when Dr. Wan An started working at Bok Mai, any antibiotics that we need to consider or prescribe now have guidelines. So, I wonder if before answering the question, Dr. Wan An could share those guidelines first? Because Dr. Kwong, I must ask for your permission, since Bok Mai hasn't signed off on it yet, so Dr. Vu didn't dare to include it. Yes, Dr. Hung.
Yes. Yes, dear professors, colleagues, and ladies and gentlemen, I would just like to add this point. The antibiotics presented at this conference are very precious, and the World Health Organization classifies them in the reserve category, meaning we reserve these for cases of drug-resistant bacteria and cases where treatment with lower-tier antibiotics has failed. Therefore, we truly hope that as you gain these new weapons, you will cherish them so that we can keep them effective for as long as possible. As for how to preserve them, it follows the guidelines that Dr. Fuang mentioned for Bok Mai Hospital. I believe it was the first time Professor County directed that this must go through the Hospital Scientific Council, with the presence of all clinical specialists, and importantly, Professor Kwong, Dr. Fuang, Professor Sun, and other specialists, to unify with clinical pharmacy and microbiology on how to use such antibiotics and determine the most appropriate indications. This has already been signed. It was signed last week, Dr. Fuang. So if any hospitals or colleagues would like to refer to it, we are ready to share it. We have also shared this with health insurance so that you are aware of our perspective, and we are unified in the hope that it will be covered by insurance and that we will use it truly effectively. Yes, the process is actually very simple. As Dr. Fuang and Professor Vu noted, there are only two main keys. First, for empirical treatment, we must carefully assess the clinical situation, the risk of drug resistance, and the prognosis for poor patient outcomes before prescribing. Also, we should actively perform microbiology tests. We highly recommend obtaining an antibiogram, both for general review and for the current patient's results, to see if any adjustments are needed. And those are the two most fundamental points, I believe, when prescribing not just ceftaroline or ceftazidime avibactam, but all other reserve antibiotics as well. We should follow this same approach.
Yes, thank you, Dr. Hong An. Dr. Fuang, please answer the question. Yes. Yes, this is a colleague's question. At the initial admission, is there a situation of multidrug-resistant bacterial infection? Does the progression after hospitalization become HAP/VAP? And what is a reasonable antibiotic treatment? Actually, I don't quite understand what you mean by this question. Does it mean that upon admission, there is a multidrug-resistant bacterium, then we identify the bacteria or the clinical condition as severe, then the patient worsens, then likely there is an accompanying hospital-acquired infection, then pneumonia, or they need mechanical ventilation followed by pneumonia, right? Well, here I also think that, as I shared in the presentation, in clinical practice, when we implement the approach according to antibiotic treatment guidelines, we base it on the severity level. Secondly, we evaluate the risk factors to answer the question of why we use that antibiotic. And in my guideline presentation, which I have already sent to you, in the section on multidrug-resistant bacteria, it also provides guidance that for drug-resistant pneumococcus, we will base it on the MIC to select the first line and alternative options. That is something we will also evaluate, right? So I think it will be based on the treatment protocol. As for here, if we have found the cause to be resistant in community-acquired pneumonia, then certainly based on the patient's underlying condition as well as the evidence, we will have to apply multi-drug-resistant treatment protocols, and whatever weapons we have, we must use them, right? Carbapenems, then using piperacillin, tazobactam, and Dr. Ann also talked a lot about maximum dose meropenem, using colistin to cover gram-positive and gram-negative bacteria, so we will definitely have to choose treatment protocols that are suitable for each individual. And in cases where we do not treat thoroughly, patients will reach the final outcome, which is hospital-acquired pneumonia as well as ventilator-associated pneumonia, and in our experience, we have seen many patients where we failed in that treatment. Moving to intensive care is like a vicious cycle, and it usually happens in patients who already have underlying medical conditions. Yes. And so, I also think that what we have in the guidelines, yes. The guidelines also introduce to you, teachers and colleagues, that there are first-line choices as well as alternative choices, so we will rely on these guidelines to make our selections, right? As you can see on the slide, for antibiotic-resistant pneumococcus, right? We will base it on the mic to choose between the first-line and alternative options, and ceftaroline has also been included in the guidelines. This is one of the antibiotics that we can consider as an alternative choice. And here, it is also mentioned that vancomycin is one of the indications for treating patients. And with vancomycin, colleagues will also need to pay attention to quantifying the concentration to evaluate whether the vancomycin level is sufficient or not. So, for antibiotic-resistant pneumococcus, we will have that approach. Yes, I would like to invite Dr. Vu. Yes, please provide the questions again so Dr. Vu can answer a few questions related to the approach. There is a question regarding the frequency of Group B drug-resistant gram-negative bacteria. We call Group B according to the criteria as metallo-beta-lactamases, and these are very drug-resistant. The prevalence of these is about 15%. Additionally, there are other types as well, totaling about 30% to 50%, depending on whether the report is from non-ICU or ICU settings, where the resistance rate in the ICU is significantly higher. Yes. Yes. For PCR, following standard principles, authors generally recommend considering any pathogen with a load above 10 to the power of 5 as a likely causative agent of disease. The second step is that if we have 2 or 3 potential pathogens, we look at which one has the highest load. For instance, if one is 10 to the power of 7, another 10 to the power of 6, and another 10 to the power of 5, we usually prioritize the one at 10 to the power of 7 over the pathogen at 10 to the power of 5. Secondly, numbers are always important, but we also await the results of the antibiotic susceptibility test, known as the standard conventional microbiology antibiogram. This is because PCR does not replace, but rather only supplements the information provided by conventional microbiology. Besides that, the penultimate point is that we usually also consider fungal or viral agents if present. Occasionally, even though statistics never mention hospital-acquired pneumonia caused by viruses, as you know from the COVID era, it spreads everywhere, so we do occasionally see cases of hospital-acquired COVID. The final point is that, as always, we must rely on clinical presentation. For example, in a case lasting over 5 days, the likelihood of a fungal infection is high. If a CT scan shows, beyond consolidation lesions, necrotic lesions with fungal characteristics, such as the halo sign or the moon sign, then we must start considering fungal causes. And if the clinical picture, microbiology, and PCR results align, we must provide full coverage. So, honestly, even though it is a very confusing situation, truly very confusing, one of the simplest ways is to cover everything. Thank you very much. Yes, another question for Dr. Vu is about the experience in treating staff that is still sensitive to vancomycin, but after 7 days, it remains positive in cultures and the clinical condition continues to worsen. Do you have any experience with cases like this? After that, let's see if Dr. Tuan has additional experience to share on this matter. Well, I would divide this into 2 cases. One case is community-acquired pneumonia. Usually, if it doesn't improve despite continuous treatment, you must test for the pantin-valentine leukocidin, the toxin that kills white blood cells, to verify if it is present. Because in the community, that strain is very virulent, and even though the community-acquired MRSA is very sensitive, its toxicity is high. That is the first point. Second, for hospital-acquired cases, we usually have to check the mic, and if the mic is 1 or higher, we consider these cases to have reduced susceptibility. Usually, it must be below 0.5 to be considered sensitive. If it is in that range, we must consider it less sensitive. And the third issue is that staphylococcal pneumonia often causes many metastatic infections elsewhere. We have to check the joints and other areas to see if it has spread anywhere else. And the principle is that surgical infections must be drained. If there are abscesses, they must be incised. You cannot rely solely on vancomycin all the time, that won't work. Yes, may I have Dr. Tuan's additional opinion? Yes, I completely agree with Dr. Vu. If a patient has sensitive staph but it is not resolving, first, you must check all joints, and second, perform an echocardiogram. In many cases, we don't see it via transthoracic echocardiography, so we must perform a transesophageal echocardiogram because there is a high risk of endocarditis in the tricuspid or pulmonary valve. So, in summary, you must find the focus of infection, and if you still cannot find it after all that, you may have to switch to another antibiotic. Yes, thank you, Dr. Tuan and Dr. Vu. It is important to measure whether the vancomycin levels in the blood are sufficient. Sometimes they are not enough, right, Dr. Hoang-An? When it's not enough, it won't be effective. Because if it's below the mic, it will not be effective. And when using vancomycin, large hospitals can now measure it. Exactly. There are still many more questions, right? Also, you asked about the experience in treating penicillin-resistant pneumococcus at TAM-AN, right? At TAM-AN, we always follow the principle that if a patient is admitted, we must always perform a bacterial culture before antibiotic treatment. We also use ceftaroline to treat cases of pneumococcus resistant to penicillin or ceftriaxone. However, we see very few such cases, and when the antibiogram shows resistance to penicillin or ceftriaxone, we don't culture many of them. It's very rare. Mainly, what happens? After doctors have treated according to an empirical regimen following guidelines, for example, a community-acquired pneumonia patient admitted to our facility, we choose to treat with ceftriaxone, a beta-lactam, combined with a macrolide or a quinolone. Depending on the case, if after 48 to 72 hours the condition does not improve and the pneumonia persists, we often consider whether it is resistant pneumococcus, resistant to penicillin, or resistant to beta-lactams. Then we usually administer ceftaroline, and to date, ceftaroline can be said to be 100% sensitive to penicillin-resistant pneumococcus. Today, we are also discussing 2 new weapons, ceftazidime avibactam and the second one, ceftaroline, for treating community-acquired pneumonia and hospital-acquired pneumonia. As you all know, its current clinical efficacy and microbiological efficacy, as well as sensitivity rates and clinical and microbiological improvement rates, are still very good and very high. And it can effectively treat cases of community-acquired pneumonia suspected of drug resistance or post-influenza pneumonia, as we might suspect MRSA infection. Another issue is gram-negative bacteria that are resistant to antibiotics. However, those are still antibiotics that we consider a group that must be protected. And the selection of appropriate antibiotics must be carried out by you according to the current professional guidelines. My hospital has treatment guidelines for the current prophylactic antibiotics, which are ceftazidime and ceftazidime avibactam. As Associate Professor Kwong just shared with me, I think my hospital should share this with all hospitals and medical facilities nationwide so they can understand and implement it to avoid the current situation where, as Professor Yosh presented this morning, out of 67 countries surveyed worldwide, Vietnam has the highest and most inappropriate rate of antibiotic use. For example, acute bronchitis and acute pharyngitis are also treated with antibiotics even though 90% of those cases are viral, so this requires us to make the correct, urgent, early, and appropriate choice. We must rely on clinical presentation and always obtain microbiological samples before treatment, while simultaneously analyzing the stratification and risk factors for multi-drug resistant bacterial infections to make an appropriate choice. Furthermore, it is also necessary to use guidelines to treat patients. There are a few points. First, one must rely on the patient's clinical condition, analyze the antibiotic resistance situation, look at local bacteria, and follow the guidelines and PK/PD, right? Those are the things we must understand very clearly when it comes to antibiotic treatment. Once again, I would like to thank the two speakers for preparing their presentations in such detail and presenting them coherently. Second, thank you to the teachers for your contributions, and thank you to all the delegates who are still attending in full and providing comments and questions at this hour. Thank you to Pfizer for supporting and accompanying us. Thank you, teachers.
Yes, and the insights shared by Associate Professor Dr. Chu T. Han have brought our Per Satellite session to a close today. Once again, on behalf of Per, I would like to extend my gratitude and best wishes for health to all of you, our dear medical staff. I would now like to invite the chairpersons and presenters to please come up to the stage for a group photo with the organizing committee. Professor, please come up for a photo.